other endpoint indicates two different mycological eradication rates at day 25. And then, okay, I see the difference now. That makes sense. There's the next line is at day 10 versus day 25. Okay, that I hadn't noticed before. That just seemed confusing, but now I see the difference. And I think it depends. It would depend somewhat on price differential or side effect profiles, whether that long-term improvement in cure rates would be enough different from fluconazole to warrant the difference. And that's subjective, and I'm just verbalizing the questions that come to mind as I read through this.
No, that's totally fair, and that's what we want. I want that honest feedback. Okay, great. What's your perception of the MOA for this product?
MLA, help me understand what you're asking about there.
The mechanism of action. Sorry about that.
It says glucan synthase inhibitor. I would assume that that's a important enzyme in the function of Candida, but it doesn't give me any more information than that. So I cannot say I have a clear mental picture of what the MOA would be for this.
Okay. And so in comparison to existing treatment options, what is your perception of the efficacy for this product? I know you talked about it a little bit with some of the clinical data.
Yeah, the impression about the difference at day 25, that seems to be one of the most convincing differences. It's hard for me to comment on the difference in recurrence because I'm not seeing how the fluconazole treatment was compared over a 6-month period of time. Now, it may have been that fluconazole was given 1 day a month over 6 months. If that's put here in the study design, I'm not seeing it. So I see a little, just the way this is being portrayed in this product profile, I'm not seeing a clear differential between acute VVC and recurrent VVC. I see the difference in how product S is being prescribed for those two groups of patients, but I'm not seeing a difference in how that was compared with fluconazole for the recurrence specifically.
And to be completely transparent, a couple of things. They haven't done any of the studies in that yet.
Sure.
So that's why. I think there's no data there. Strong.
Yeah, and that makes perfect sense. So as a clinician, that raises a question in my mind. It's nice to know that only 4% required rescue therapy, and it's nice to know that the secondary endpoints were followed out for 6 months. But to claim that this is better than fluconazole for recurrence, I don't see data here to support that contention if that is something that the company were wanting to promote this product for. I think that the benefit that I see in this profile is for the acute. I think it's nice to know that it's been used.
Anywhere from $20 to $50 out of pocket. So that 10% that you said still stand then?
Yeah, if that, it would be a very small minority with a price differential.
Okay. And so then now let's talk about both products are anticipated to be approved for recurrent VVC. And so your next 100 patients that you had with that, would you see yourself dividing up those 100 patients?
If I had to guess, I might say, 20% with, the product S, and maybe, 5 or 10% product M. That's quite subjective, but my first impression.
And so you said what, 5%?
Mm-hmm.
5 to 10? Okay. And I know that's a hard exercise. That's what I've heard from a lot of people. And so then thinking about I just have two more questions for you. And did you do any kind of segmenting of the patients in your mind as you divided up those percents, or was it based on what we talked about previously, what they acute versus recurrent?
I think, and I'm specifically speaking about recurrent, I think the patients who had been treated with some other regimen of some product for recurrence in the past, and again, all of us OBGYNs have our go-to, whether it's 2 weeks of fluconazole or, we take it for a few days each month or whatever we do, somebody who had done that in the past and still had recurrence would definitely fall into a category of trying, one of these products. And another thing, because neither regimen is completely simple, I would want to assure, at least until I was more comfortable with the medications, that the patients I chose were educated, interested, and willing to put effort into a less than completely simple regimen. Not that it's difficult. It's just they can't take it this month and next month and then forget and come back 2 months later complaining they had recurrence. So somebody who's going to seem committed to following through.
Okay, great. All right, and so my last question is regarding nurse practitioners. Do you have any nurse practitioners in your office?
Not at this time. I have in the past worked frequently with nurse practitioners. I do have to be honest that I am not in my current position working with them.
Okay. And do you see any future role for them in your organization?
Probably not in the organization where I am right now. I will say that in the OBGYN practice as a whole, I do see their role increasing.
Okay, great. And is there a specific patient that you think you would have them see versus yourself?
I think VVC patients would frequently be seen by nurse practitioners. That would be considered a low-risk patient and something nurse practitioners could follow a protocol for very easily. So this would definitely, pretty much most VVC patients, unless they had other medical problems, there would be protocols that nurse practitioners would feel comfortable treating either acute or recurrent VVC for.